We had a great session on diagnostics, ultrasound, clinical exam, so forth. I'd like all the speakers from this afternoon's session to come to the table and answer some questions.
It's difficult, but what I think you have to understand at the outset is a lot of people, when they design a paper, design the outcome and then they design the paper. And when I look at a lot of the naysayers, it looks like they designed the design and then they did the study and said, oh, look, it really is a no paper. But a lot of the papers that I read, if you just gloss through them, it looks like they did the same protocol, the same technique, and so on. But if you actually take the time to dissect out through the papers, they didn't. But more importantly, what was done in Canada not very long ago, and it's embargoed data at this point, but it's going to be published, I hope. The CCSVI, I believe, funded a couple of folks to review the literature, and I know the guys that did the review, and they presented the data to the CIHR expert working group that are supposed to be the gurus on research in Canada. And the opinion of the CIHR went from you can't do research to you should do research overnight. So if you actually take all the data, break it down, and do an analysis of the actual data, you find it actually is quite supportive.
So has been done this job to try to compare?
That has been done. Yeah, they're comparing what was comparable. Well, the result was the CIHR and the ministry and the Minister of Health in Canada changed their position from no, we're not going to fund any research to yes, we're going to fund research because the data supports it. That was the outcome.
Treatment research.
Yeah. Treatment research.
Yes.
Yeah.
Yes.
I understand from Dr. McDonald's excellent talk that the criteria to be used for follow-up ultrasonography is still a little bit in question, and at least for now we should probably be following as close to the Zamboni protocol as we possibly can. Is there some consensus among the people involved in the room and up on the panel about when we should do follow-up? Should we do immediate post-24 than 3, 6, and 9? 3, 6, and 9 months? Or are there differences in opinion on how we should be doing that follow-up?
I don't think, from what I've read, that there's any uniformity in opinion. When I talked to Paolo, he was suggesting you do it post to make sure you don't have thrombus immediately post-procedure. Then he was suggesting 3, 6, 9, 12, 18. I think everybody's got different protocols, but that's the protocol that I've been using for follow-up. Karen?
We use 1 month, 3 months, 6 months, and a year.
And nothing immediately post?
No.
There are other people that say don't do anything until you get symptoms again.
So what we are doing, usually we recommend the Doppler follow-up after 6 months, but we ask patient that if there is a worsening of the symptoms, of course, it's a good reason to check such a patient area. Also, when the procedure was not very successful, we recommend to the follow-up area. Sometimes we are unable to do a very successful angioplasty, and we try to improve the flow a little and look what happens later on. But of course, there are no recommendation. The data are very limited.
Back there? Yeah, you. Can you speak louder?
I had one patient that had 3 ultrasounds done elsewhere and came to me for the ultrasound. I did the 4th ultrasound that was grossly abnormal. We did venography and venoplasty, and the patient has gone from being absolutely crippled with the symptoms to being asymptomatic. So it really comes down to technique of doing the investigation. It sounds easy, it isn't. I mean, if you've got a technician that hasn't been trained by somebody like Karen or Zamboni, or somebody that actually has been very well trained, then you maybe want to send them off and get them retrained, because I think the training is critical.
Also, there can be isolated stenosis in azygos vein. and this vein cannot be assessed by means of ultrasound. So there is still a good chance that this patient present with azygous vein pathology.
But when you get a zygous vein pathology, you may see some aberrant flow in the vertebral vein going anteriorly instead of...
No. I do not agree.
Okay, so we're going to disagree.
I don't think that you can assess the flow in the vertebral veins looking at the vertebral veins. There is no anatomic or other physiologic evidence for such thinking.
Wait a couple months, I'm printing a paper.
So Karen and I would agree, and Marian would disagree.
And we followed it up with our premise patients.
But
I
what
don't
The question is, why not just perform venography, and
venography
skip the ultrasound?
Right.
Arteriography.
but
Why?
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 Where? In arteries? What is not?
Delayed.
But you cannot see precisely the intracranial veins performing arteriography.
I don't agree with you can see a faint venogram. It may show you contour normality, but to pick up the subtle abnormalities of the valves, I think that'll be very challenging to do on arteriography. Also, arteriography has a life-threatening risk, which venography does not have. I think that the examination should begin at the dural sinus anyhow. I think we have to prove continuity of the dural sinus into the jugular vein. So you can see the dural sinuses from the venous side better than you can see them from the arterial side. Yeah. Could you speak louder?
Is there a role for CT scan?
Probably not. Most of these problems are problems with valves, and these structures are very poor visible in a CT scanning. Even if they are, the flow cannot be assessed correctly. There is one study coming from Buffalo and was negative.
I think I'd talk to that in a little different way. I agree with Miriam that CT venography is useless for a jugular vein, but CT venography may play a small role in assessment of the azygous.
Yes.
But I think that's the only place it plays a role. We did some CT venography of the jugulars, and we found them totally useless. They didn't correlate with MRV, and they didn't correlate with conventional venography, so I didn't do any more. I didn't do enough for statistical significance, but they were just useless.
Perhaps yes.
Yeah. Yeah.
You know, we see sometimes mid-jugular vein compression and narrowing persistent. Not only the ultrasound, also venogram shows that area. Before and after balloon angioplasty, it's persistent. And that area sometimes looks narrowest area actually, more than the abnormal narrowing, pathological narrowing. Low end here. So what do you make out of that kind of findings? We should go after that, or it looks narrow, even venogram, after balloon.
You mean the narrowing in the middle part of internal jugular vein?
Yeah,
Yes. Yes.
it's like compression by the prominent muscle
Yeah.
instead of narrow.
So we are finding such things in some of the patient, and actually we have no idea how to manage these lesions safely. Of course, balloon angioplasty will not work at all because it's a compression from outside. In some of this patient we implanted stent, but in some of these cases there is a huge intimal hyperplasia. So at the moment we don't implant stents in these cases, and Maybe in the future we'll find a solution, but for sure neither balloon angioplasty nor stenting is not a good idea. Something different should be invented.
Can we confine the questions to the ultrasound assessment? Because tomorrow, Karen, none of these people have no experience or very little experience actual treating. So tomorrow is the day for discussion of the treatments.
Yes, but regarding sonography, yes, we see these problems, and usually these are only secondary collapse of the vein, and the main problem is on the valve. But in some cases, this is a primary problem. This compression in the middle part.
Right. Patient came back for follow-up ultrasound. We saw same thing. So we said persistent error. And the patient had recurrence.
Yeah.
In some of those patients, I've seen what looks under ultrasound to be a slip of the sternocleidomastoid.
Yes.
A
No,
variant
exactly.
is actually within the vascular sheath. And the question would be whether or not ligating or dividing that would be it. But I don't think anything would be inside.
I agree. It's external. A lot of these patients, too, if you look in longitudinal on ultrasound, you actually see the muscle coming in. Always make sure you go transverse right at that muscle, because the vein has the ability, instead, it's not round like an artery. It'll go oval, and your volume would still be the same. Not all these patients. Some of them are, like you said, it's in the sheath, so nothing, it's going to compress, so it will affect. But always check in transverse. You check in longitude, check in transverse, because it just might be flattened out, but it'll be widened. So your volume is going to be the same, so it's not a true stenosis. Just double check on that.
Just two comments. One, we do the ultrasound within 1 week after angioplasty. For us, that's something really useful because we detect early thrombosis, and then we can decide if we want to do something about it. So that's just a comment regarding early ultrasound angioplasty. And the other thing is, it was interesting for me to hear that you scan them in neutral position and you avoid turning the head away. I do IVUS in all patients, and actually, when I do IVUS, of course the patients are supine, and when they turn around, if let's say I'm evaluating the right jugular vein, I make them turn the head toward the left side, and that actually opens the vein completely, and it doesn't compress the vein at all. Now, if the patient turns the head toward the right side, the vein is totally collapsed. But the interesting thing is that the vein at the base, where most of the problems are, is not affected by the diffuser. So, I mean, I just was curious about
As-
about saying, that you scan them
It's a physiological behavior of the veins. There are some papers on this, and when you turn the heart right or left, you can produce this pseudo occlusion.
Yeah, that's exactly what I'm saying. But if you turn the head towards the contralateral side of the side that you're evaluating, the vein is totally open. So I'm just curious about that.
We have some patients with this narrowing stricture of the vein, which was only visible in this body position, and of course there was no indication for a procedure, and we just recommended patient to avoid this position when this vein is closed.
Makes their insomnia worse if they sleep that way.
Also, you might not see, you might get a good flow here, but up top, you're compressing it up higher, or you might not be able to see it with your ultrasound, but it's affecting the flow through the midsection. Okay.
Yeah, along those same lines, there are questions about what the variance in rotational
Speak
occlusion,
louder.
what kind of variance you see in rotational occlusion. Is it 50 degrees, 80 degrees, whatever? Have you measured enough people to see a lot of variance?
I'm not. None of us understand you.
Put your question another way.
Just talking about rotational occlusion, you turn your head and you shut down the.
Please speak to the microphone.
I can hear myself really loudly. I'm sorry. He was talking about rotational occlusion, and I'm wondering if you've noticed a lot of variance. If you can say, like, if occlusion at 30 degrees is abnormal or at 60 degrees is abnormal.
Okay, are you referring to the position of the head or the position of the body?
The head, if you turn left, it compresses the left vein, either by styloid or the bone behind it.
Personally, I've never had, well, I shouldn't say never. When the patient, I always keep them in neutral position. I don't see that. If I get an occlusion or no flow detected, I have them turn their head just in case it is muscular. And I've never had the case so far where it has been muscular, because they've always been in neutral position and I've never had a problem. And I just double check.
One of the papers that was written and is off-quoted, and I won't name the author because it doesn't matter, what he said is a lot of the altered flow that you see was attributable to the pulsations of the carotid bulb, and because of the position of the neck, it was pushed down the vein. And that's just a reflection of a study done being in a way that Zamboni hasn't done it. It's some new technique that somebody's developed that's useless.
The overwhelming majority of true stenoses are around the confluence with the subclavian vein. So if I see what looks like an occlusion or a stenosis in the straight frontal position on a venogram, I will turn the head to both directions and do repeated venograms to see if that relieves the obstruction, and it always has. So I don't know if that answers the question, but now we're getting into venographic questions. We'll hold that till tomorrow. Any other? Yeah, one more?
Yes, my question is for Ms. Marr. Did I understand correctly that you're imaging the jugular vein in transverse to get your waveforms?
No. Longitudinal. Always use longitudinal. We use longitudinal for color assessment. We use longitudinal now for our velocities, our volumes. Transverse is used now for just CSA. Our phase 1 study, no. Our phase 1 study, we did exactly like Dr. Zamboni's protocol, sorry to say, and his was always transverse assessment. He used transverse for his spectral analysis, but his spectral analysis was more, it wasn't for velocities, it was just for direction of flow. Okay, just to verify what he saw in transverse color. Next. In transverse?
No, obviously longitudinal. You couldn't do it in transverse.
Good question. Good question. Thank you. No problems in longitudinal.
Okay, thank you, panel. Thank you.
Just an aside, what Karen is describing in CTEV isn't what Zamboni's describing in his paper. They're two different techniques to some extent.
Okay, thanks.